Good afternoon, everyone. Thank you for joining us for the Understanding Autism Spectrum Disorder webinar. My name is Crystal Reynolds, and I am the Director of Marketing for the Family Institute at Northwestern University, where we, through research, education, and therapy, practice relationship-based behavioral health care and are committed to strengthening and healing children, adolescents, and families from all walks of life. Today's webinar will be led by Dr. Renay Gartner and Dr. Amy Wolok of our Neuropsychological Assessment team. Dr. Gartner is the Director of the Assessment Program at the Family Institute. She specializes in neuropsychological assessment from early childhood through adulthood. She has significant experience in training, helping individuals and families determine where their true struggles lie in order to inform the most appropriate support and services and help them live up to their potential. Dr. Wolok specializes in pediatric neuropsychological assessment and works with children and adolescents from early childhood through young adulthood. She brings more than 10 years of assessment experience through her specialized training, helping children and families reach their potential. Thank you both for joining us today.
Thanks. Thank you. All right, so I am going to share our screen real fast so you can see our presentation. Bear with me. Okay, so today, as Crystal alluded to, we're talking about autism spectrum disorder. So specifically in the webinar today, it's going to highlight what is autism and how it's diagnosed, how it's presented, changes to autism and the changes to the rates of autism throughout the years. Different treatment options, and then some trends that we're seeing in the field. So to get started, a little overview of autism spectrum. So autism is a neurodevelopmental disorder, or I'm sorry, a neurodevelopmental condition. So what that means is that the onset is during one's developmental period. So the early developmental stages is when we typically see the onset. First symptoms of autism are usually as early as 12 to 18 months. They often include language development or delayed language development. That's one of the easier things or deficits to be able to see in a young child, as well as potential of lack of social interest or unusual social interactions that we would expect to be a little bit different for an infant or a young toddler. Then throughout the early developmental period, when we're talking about the second year of life, what typically starts to pop up are some of these odd or repetitive behaviors that we're going to talk about in a bit with regards to diagnosis, as well as an absence of typical play that we want to see in a 2-year-old. And typically diagnosis is usually considered reliable at or just slightly after that 2-year mark. When we think about heritability, it's a big range, but what the current research says is that it ranges from about 37 to 90% based on twin studies. So, unfortunately, we don't have a perfect ratio there. There is a range, but we do suspect that there is some genetic component. Another area that we're going to highlight throughout the webinar, but I also want to bring up that, we say autism or someone may be on the spectrum, but the full name is obviously Autism Spectrum Disorder. And the word spectrum is important here because it is a spectrum of deficits, meaning the severity and the manifestation of the problems really vary per individual. So autism or autism spectrum disorder looks really different in everyone that is presented, is assessed, is potentially diagnosed. It relates to also one's developmental level, it relates to their age, their language. So assessment is very comprehensive and it can be really challenging, which I think why there's a lot of research and discussion in the field, and we'll talk about that. Lastly, before we get started, so I wanted to bring up kind of the hallmarks of the diagnosis. So there's 2 main areas that we look at for deficits or main hallmarks. So the first one is this social piece. So individuals that are diagnosed on the spectrum or with autism spectrum disorder, we always see a range of deficits with social reciprocity and social communication or interaction skills. And then we also see a behavioral piece. That's the other side of the diagnosis. So this could be the presence of restricted or repetitive behaviors. So we have the social side and we have the behavioral side. I'll talk about that in more detail and what that means, but just kind of give a really broad overview to start with.
So we know that the prevalence of autism has changed dramatically in the last 2 decades. So here I have a line graph showing the years of 2000 to 2020. So just 2 decades, and we've seen significant differences in prevalence rates. So in 2000, the rate for diagnosis was 1 in 150, or less than 1% of the population. In 2012, that number went to 1 in 88, which was just over 1%. And in 2018, it was 1 in 44, which was equivalent to 2.2% of the population. And then the most recent statistic that we have is from 2020, which gave the number of 1 in 36, which is 2.7% of the population. So we know that diagnosis is increasing, and we know that the diagnosis has always been higher in males compared to females. So at one point, the ratio was 4 to 1. Boys diagnosed 4 times more than girls. And now the current ratio, it's still pretty high. It's 3 to 1. Toward the later end of this webinar, we're going to talk about what we think could be the potential underdiagnosis of girls with autism and kind of the different changes and presentations that they come with. So what happened? Why are we seeing such an increase over the last 20 years? Well, we don't have that answer. We don't really know, but we can make some assumptions based on some of the things that have happened during that time period. So in 1990, so this was just a decade before this line graph starts, autism became a category in public school systems to grant special education to kids with autism. So prior to this, autism was not formally recognized in the public education system. So from 1990, it became a category and continues today. So if a child has autism and needs support in the academic setting, it gives them access to what's called an individualized education plan, or an IEP. So basically, this really meant that there was increased recognition of autism as a neurodevelopmental condition and its impact on the child in the school setting. Then in 2001, a measure that we still use today to diagnose autism was made widely available. This was in 2001. It's called the Autism Diagnostic Observation Schedule, or the ADOS. So in 2001, it was published by a well-known publishing company and quickly became known as the gold standard in autism assessment. So basically what this allowed was for psychologists and other diagnosticians to not only be trained, but be given access to materials that would allow us to reliably and validly diagnose autism in clinical settings. So that was huge. Then in 2005, the foundation called Autism Speaks, which is very well known today, was founded. So that was just in 2005. And that was after Suzanne and Bob Wright were inspired by their grandson's diagnosis of autism. And today, the Autism Speaks organization remains one of the top in research and advocacy in the country. Then in 2013, there was a major shakeup in our diagnostic manual. So the American Psychiatric Association publishes what's called the diagnostic, the DSM, the Diagnostic and Statistical Manual of Mental Disorders. So it's what every psychologist and psychiatrist uses as a framework for diagnosis. So in 2013, they published their 5th edition of the DSM. And there was a major shakeup with autism and its subcategories. So some of those changes included the removal of Asperger's syndrome. So prior to 2013, this was a diagnosis in the DSM. And basically Asperger's was considered a higher functioning presentation of autism. So you still had the same symptoms and categories of symptoms, difficulties with social interaction, rigidity, restricted repetitive behaviors, but they were considered less severe and less impairing. Well, with the 2013 edition, what researchers realized was that Asperger's was really autism, and they really shouldn't be separated. So the new classification system renamed what used to be autistic disorder to autism spectrum disorder. So it took in Asperger's and basically described what Renay was talking about, this really, really wide spectrum where you have individuals who are nonverbal and unable to care for themselves at all to extremely gifted IQs and running worldwide companies. So it really is a spectrum, and it makes diagnosis challenging at times because of that. But really what the new diagnostic classification system did was it made the categories more specific, and it spelled out the symptoms in a clearer fashion. So now we have kind of a 2-categorical diagnostic system, with the social communication and interaction being one, and the restricted and repetitive behaviors being the other. Another change to the 2013 diagnostic manual was the addition of a new diagnosis called social pragmatic communication disorder. So this was really interesting because this basically describes the first category of an autism diagnosis without the second category, the behavioral piece. So oftentimes what we see with someone who has social pragmatic communication disorder, we can see trouble relating and communicating with others through language. Often their nonverbal communications are affected, so they might have difficulty picking up on social cues like facial expression and body language. And obviously this makes making friends and even wanting to engage and feeling confident to engage with others pretty challenging. But again, with this diagnosis, there are no restricted or repetitive behaviors.
Okay, so now thinking in the current system that we use, the current manual, how do we diagnose, or what is the diagnosis of autism spectrum disorder? So I'm going to go through it, what the diagnosis is, And then we'll kind of bring it into what it probably looks like or what it can look like for an individual. So here you have kind of the cover of, we've been referring to this DSM, or the Diagnostic and Statistical Manual of Mental Disorders. We are currently on the 5th edition text revision, which was from 2022. So it's actually very, very recent. The most current, which is, pretty current, which is lovely, for sake of this presentation too. So what Amy spoke about just a minute ago is there's 2 overarching areas of deficit that someone needs to experience in order to have a diagnosis of autism spectrum disorder. So I'll go over each one. Also of note that is important to recognize is that the individual needs to be experiencing the difficulties currently or by history. So that's why it's so important in diagnosis and assessment to be able to get as much information, to go as far back as we can to see someone's history. So the first overarching area to make a diagnosis is on that social side. So specifically, we need persistent deficits in social communication and social interaction across multiple contexts. So this doesn't include the kiddo that really just struggles at home, but it has no difficulties at school, has friends outside of the home setting, but only is struggling in the home. So this we probably want to take a greater look at, because we typically see it across multiple contexts. So within this persistent deficits of social communication interaction, there are 3 areas of deficits that we need to see. So the first one is what we call social emotional reciprocity. So this is the failure of that back and forth reciprocal conversation. So you say something, may have a question or kind of asking for more information. They say something back, also adding more as the conversation flows back and forth. We want to see a reciprocal nature. A lot of times individuals that have deficits in this area really struggle with that back and forth. Also included would be a failure to initiate or respond to social interactions, or also a reduced sharing of interests, and also to kind of get someone else in their interests or share the interests of others. Next, within that overarching area is nonverbal communication. So nonverbal communication is used for social interaction, which is why it's in this category. Like, for example, hard to do it today on a webinar, but if we were in person, I would be looking at everyone's nonverbal behavior right now. I would want to see how they're communicating. Are they listening? Are they interested? Are they not interested? Are they confused? Are they listening like really intently? Are they like on their phone or not paying attention? All of those things give me a lot of nonverbal communication to be able to amend my behavior based on what I'm noticing, to be able to utilize that communication piece. Other things that we look at that individuals that with this diagnosis may struggle with are gestures. So you see, you might be able to see, but I'm using my hands a lot. I talk with my hands, but that's my use of gesture right now. My changes in facial expressions, if you get really excited or you are really upset about something, your facial expressions are going to change to convey that nonverbally. So we want to see if they're able to utilize nonverbal behaviors to communicate. And then the last area of this social domain is deficits in developing, maintaining, and understanding relationships. So this reflects their ability to adjust their behavior based on the social context. So as an example, an individual will likely act differently with their best friend as compared to like with the principal. So we want to see them socially appropriately adjusting their behavior given the context. They may also struggle with making friends, have an absence in peers, and also using imagination in their play. So that's the first area. The first area, again, is the social aspect of the deficits that we notice in order to make a diagnosis. The second area of deficits, as Amy alluded to before, is the behavioral side. So in order to make a diagnosis, we need 2 out of the potential 4 areas of behavioral deficits. We only need 2, but we need 2. So the specifically what I'm talking about is what is called restricted or repetitive pattern of behaviors interests, or activities. So there's a couple examples that I'm going to give you and bring up. So first is stereotyped or repetitive behaviors or movements. So these could be repetitive motor movements, such as like rocking, hand flapping, clicking. It could also be lining up toys in like a repetitive manner. The next area could be insistence on sameness or inflexibility. These are those kids that really need a routine. They're really distressed with small changes. They want the same food every day. They have the same greeting rituals. The flexibility is difficult for these kiddos. The next area is restricted interests. So these, we're going to talk throughout about this in different details throughout the webinar and give you some examples. But this is basically restricted or fixated interests that are more abnormal in intensity and in focus, and they continuously to pop up at times that maybe not be appropriate, this area of interest that someone may have. And then lastly, I think it's a very classic example that people think of is the sensory concerns. So they have sensory sensitivity, whether it's hyper or hyporeactive to sensory input. And I think it's important for us to recognize that we only need 2 behavioral deficits out of the potential 4. So sensory is one of those, but this doesn't mean that you have to have sensory sensitivities in order to make a diagnosis, as long as you have 2 other areas of struggles. So I think that's a common misperception that we notice in terms of, well, my child is on the autism spectrum because they have sensory sensitivities to sound. Not necessarily. They still need another behavioral deficit and all the social deficits as well, but it's something that we hear a lot. So I wanted to bring it up. So those are the main 2 areas of deficits that we have to have in order to make a diagnosis. Also, there has to be symptoms present in the early developmental period. So if someone is having difficulties pop up when they're, 17 or 18, and there's nothing by history, it's something we're going to want to look at a little bit more. We're going to want to dig in and take a better history to make sure that there's nothing present there, and then see if there's something else going on that might be triggering some of these struggles that someone's experiencing. It's also important to note that struggles may not always manifest until there's increased social demands. So a 2-year-old social demands, or even a toddler, an infant social demands, are very different than a 4-year-old or 5-year-old social demands with school, with play dates and friends. So sometimes that's when symptoms present a little bit more and vocalized because the expectations are higher. And then lastly, in order to make the diagnosis, there needs to be impairment. So this individual or within their environment, we need to see impairment, whether in their social functioning, their academic functioning. So we need to see some of that deficit causing impairment. So now what we have is we have a really quick little clip that we thought was good to just kind of give some illustration to this diagnosis.
No 2 kids on the autism spectrum are the same, but there are some common behaviors you might pick up on. Sometimes children on the spectrum have trouble talking, playing, and being with other people. They might show this by not looking at you, avoiding eye contact, not smiling or using other facial expressions, talking over the top of you or being really loud when you need them to be quiet. Children on the spectrum sometimes like routine and repeating things. They might like to do something over and over and over again. Copy words and phrases, saying them repeatedly instead of talking. Repeat the same movements like rocking back and forth. And keep asking the same question, lining up objects. Be fussy eaters, only eating certain foods. Get upset if routines change, like driving a different way to school. Little ones on the spectrum might have more sensitive senses, like hearing, taste, touch, such as brushing their teeth, which to them feels weird, or too much noise, like in a playground or a big family group. Sometimes they might refuse to eat a food because it smells or they don't like the texture. You might notice these things a little or a lot, as early as when they're bubbers.
Okay, so let me get back to this. Okay, so we just thought that was a nice little illustration of some of the diagnostic criteria that we just talked about. So next, let's talk about how it may present. So we showed you a little bit in that clip, but let's talk about some of the challenges, more specifically of what someone may experience or what we may notice. So 3 categories that I'm going to talk about. So the first category are social communication challenges. So as an example, individuals with autism spectrum disorder, typically really concrete. So they're more literal. So expressions and sarcasm, even sometimes jokes, can be a little bit harder for them because they're more abstract. The really big struggle with this is kids and adults, we don't say what we mean. We talk with expressions. Some people are more sarcastic than others, but we expect whoever we're talking to, or whoever's around us, to know what we're saying without us actually saying it. So that can make it really challenging, this social communication piece for kids that are on the spectrum. Another social communication challenge are poorly utilized gestures. So nonverbal behaviors, as we talked about, are really significant for communication. So as an example, if you're having a conversation with someone and they're not looking at you, they're not making appropriate eye contact, at least for me, in my mind, if I don't know that they're having this a deficit with nonverbal communication, I may think like they're not interested, they don't like me, they don't like what I'm saying. So that can create a little bit of a challenge. Also, someone's facial expression, their tone or different intonation gives really useful information for communication. And an individual with autism may not pick up on those small nuances, and they may not also be able to produce those nuances and utilize nonverbal communication to help their listener know or understand what they're thinking. Another example that I had of just a kiddo that I worked with, they constantly thought people didn't like them or people didn't want to socialize or be interested in them. And they gave me the example of like someone was across the room at school and they were like, you know, can't really show on here, but they were like, had their arms crossed and kind of like a furrowed brow talking to a friend. And they had assumed, well, they don't like me because they have their arms crossed. And that means they don't like someone in their vicinity. But in reality, there's so many things that could mean. It could mean that they're cold. It could mean that they're confused. It could mean that whoever they're talking to, they don't like what they're saying. It could mean so much. It doesn't necessarily mean that they don't like the person across the way, but with someone with a social communication challenge, they may not always understand that. So it can be really, really challenging for some of these kiddos. Next are just overall social challenges. So, you know, if we recognize it or not, we are social beings. We socialize all day long, even if we're sitting on a computer working from home. We are constantly socializing in one form or another, especially for school age kids. I mean, they're with kids all day long. So one of their social challenges may be the struggle to understand and express their own emotions and also understand other people expressing their emotions. So one of the questions we always ask kiddos is, when have they ever felt at insert emotion? So it could be anxious, sad, relaxed, content, happy. And then we may ask them, like, how does that feel? What does that look like when they experience that emotion? And then we also want to see how they understand it in other people. So there's a variety of ways that we try to assess for that. But some kids maybe they've had some work in the past and they're really good at understanding their own triggers, their own aspects that make them frustrated or upset, sad or happy, but they really struggle to understand it in the other person and also even understand their role in creating an emotion in another person, whether it's bringing someone joy or bringing someone frustration, like a sibling maybe. Another area I talked about a little bit on diagnosis, but reciprocal conversations can be a really big social challenge. So especially at school, especially with all the group work that's done, there's a lot of reciprocal conversations, and especially if, you know, they have to do a group project together. So kiddos with autism spectrum disorder often struggle with this to and fro of reciprocal conversation. Also, socially, they may feel overwhelmed in social situations, like you saw in the clip. They may also struggle to gauge their own personal space. So some examples that we see are they may get too close to someone and not realize that it's like personal space. They may walk between people that are talking, not realizing that's not appropriate, or even be overwhelmed in social situations with a lot of people, like you saw in the clip. And then the last area I want to bring up for social challenges is seeking comfort from others. So, I have a 2-year-old, and when she's really upset or if she's sick, I expect, and I guess I hope, that she like cuddles with me and she comes to me for support. But 2 or 22, we want to see the appropriate amount of seeking support and seeking comfort in a socially appropriate manner, given the situation. And people with autism don't always seek that in an appropriate manner. So that's something that sometimes we're able to notice. Lastly, the behavioral challenges. A couple examples that I'm going to give here. So first of those ritualistic behaviors. In the clip, you saw him lining up the pencils. They needed to be perfect. Sometimes we see kids lining up different toys, cars, variety of things, really needing it to be perfect before they can move on to the next activity. We also, it may present as repetition of speech, or we call this echolalia, where they repeat your nuances of speech, the speech sound, the actual words, and also repetitive behaviors or movements. We saw the rocking in that one clip. Next, we have the narrow or specific interest. So I know both Amy and I have already talked about this area of interest, and I want to give some detail to it because I think it's more than just someone that really likes dinosaurs and knows, the different dinosaurs in Jurassic Park. It's more intense in a more abnormal way than we would assume as like a 7-year-old. So one example is, some kids really like trains, for example. That's normal, developmentally normal. What we would say is more increased interest is, for example, a kid that lives in Chicago or suburbs or someone in the area, and they know the train lines in the city with such intense interest and focus. So for example, they know all the train lines, they know the conductors, they know the schedule, they know the year they were made, they know every single stop on every single line, they know when the maintenance is, they know everything. And they're super knowledgeable about it. So they know that, and they like to talk about it at times when it might not be appropriate. So maybe, your son comes home from school and you're asking him about am I supposed to bring you lunch tomorrow, or are you getting the lunch on the field trip? And all he wants to talk about is we're going on the train to the field trip. We're going to take the red line and we're going to get off at State Street. And so it's harder to continue with the conversation as needed. So that would be a behavioral challenge. Also, kids with autism will struggle in the academic environment, as we kind of have talked about a little bit. And a lot of this is because of the socialization and the social interactions that are required in many academic settings. So because of some of these deficits in social communication, social interactions, it can impact their academic achievement, especially if we think of group work or participation. There's a high level of socialization that's required. Also, if we think of executive functioning, so these kiddos can struggle with flexibility and transitions. And we know, in school, you are not sitting in the desk and not moving all day long. There are transitions all day, even in your desk with what you're talking about, the lecture that you're doing, when you get a break. So we notice some struggles with executive functioning that may have an impact on their academics. Lastly, just to bring up adult individuals with autism spectrum disorder. So this independence piece can occasionally impact some of them. So for example, some individuals with autism really struggle with rigidity and needing a routine, and adult independence, there's a lot of flexibility that's needed. There's a lot of novelty that's needed. So they may struggle if they're very, very rigid. So we do notice that within the adult presentation at times.
So we've talked a lot about the symptoms of autism and how it presents. And it's important to also highlight the flip side of that. There are a number of strengths that go along with autism. To begin, logical reasoning. Often their ability to solve complex problems and see solutions from different angles is really quite incredible. At other times, they can show strong visual attention and have a really keen eye for detail. So they might notice the smallest minute visual details that other people would not have noticed. They often have a really strong memory and they're able to retain information very well, even those very, very fine details. Like Renay gave the example of the train system and knowing all the stops and all the colors and even the schedule. That takes a lot of memory capacity. With autism, often these individuals have a really strong moral compass. So they like things fair, they want things to be just, they have a strong sense of right or wrong. Then a couple more, they're honest. You know, they say what they mean and they want the same from you as well. They speak what's on their mind. They're also very reliable when they say they're going to do something or be somewhere. Oftentimes they mean it. And then lastly, they show a lot of passion for their interests and ideas and really dive deep into whatever it is they might be interested in at that time. And perhaps one of the best examples of someone with these strengths is Temple Grandin. And I'm going to show a clip in a minute, but Temple Grandin was born in the late 40s. And this was a time when really little was known about autism and its treatment. And her life is incredible. She used her strengths and passions to earn a PhD, and she made revolutionary changes to the way that livestock are handled in a humane manner. So here's a short clip of Temple Grandin.
You know, you never get cured of autism. But what you do is you learn about it, you learn more and more things.
Well, I didn't speak until I was 4. Now I have a BA and a master's, and I'm studying for my doctorate.
I can remember the frustration of not being able to talk. I couldn't get my words out. My speech came in gradually, a few words at a time. When I was a little kid, I was very autistic, nonverbal, rocking, you know, that's the kind of kid they just put away in the institution. But I had a speech teacher that worked really hard with me, and I can't emphasize enough the importance of young children getting early intervention. You got a 2-year-old or 3-year-old with no speech, don't wait. High school is absolutely worst part of my life. Teasing. I got kicked out of school for throwing a book at a girl, teased me because, you know, teasing really made my life miserable. And the only places I could get away from teasing was the specialized activities. Things like horseback riding, electronics lab, model rocket club. The line was drawn in the sand. I was not allowed to become a recluse in my room. I had to get out and do things. I'm always kind of baffled at just how illogical people are in their thinking. I'm very logical in my thinking. But when I was younger, I didn't know that other people thought more in words. You see, I think in pictures. If I don't have a picture, I don't think. And my mind is very, very associative. Being a visual thinker, I tend to put things into categories. You see, autism is a very big spectrum. At one end of the spectrum, you got half the people at Silicon Valley. And then at the other end of the spectrum, you've got somebody who's very handicapped, remains nonverbal, is going to have to live in a supervised living situation. Really, really big spectrum. And, you know, Einstein probably be labeled autistic today in a lot of school systems because he had no speech until age 3. I'm interested in seeing something that makes real change. I've done a lot of work that's made a lot of improvements in the livestock industry, and I think I've helped a lot of kids succeed. I want to see the kids that are like me succeed. That's the kind of stuff that makes me happy, when I see the things that I do make a difference.
Can't go, do this to clear out stuff.
All right.
Okay, so that's Temple Grandin, and she has written a number of books. She has a number of movies. She's really just had an incredible life. Okay, so the assessment of autism, this is what Renay and I do day in, day out. So we know that approximately 50% of kids are diagnosed by 36 months old. And the 50% of these kids typically are more severe on the spectrum. They're the ones that don't have speech, really little to no interest in those around them or their environments. So really they're caught earlier, usually in the pediatrician's office during one of the well visits. The pediatrician will have you fill out a pretty standard questionnaire to make sure that your child is meeting developmental milestones. And that's when some of these kiddos can be flagged. And it's a good thing that they are, because then it gives them access to the early intervention. The other 50% of kids are diagnosed later, or when maybe they start preschool and they really start having the opportunity to interact with other kids and other people. And that's typically the population that Renay and I see here at the Family Institute. Typically kids ages 3 or 4 and up. So who is qualified to make a diagnosis of autism? It's a very major diagnosis, and there's a lot that goes into it. So there are a number of professions that are qualified to do so. You have developmental and behavioral pediatricians, which are not just your general pediatricians. These pediatricians have specific training in neurodevelopment and behavioral divergence in kids. Then you have neurologists, psychiatrists, clinical psychologists and neuropsychologists like Renay and myself. And then even schools can make a quote unquote educational diagnosis. So it's not a clinical diagnosis, but they're able to make a diagnosis on paper in order for the child to be eligible for specialized services in the school. So let's talk about the neuropsychological evaluation. This is what Renay and I do. What does it look like? What is the process? How do we do it? So it's comprehensive. With kids that we see, we always want to see them at least over 2 appointments. And this is for a variety of reasons. Oftentimes kids can come in and they're shy and not really want to engage. And then by the end of that first appointment, they're comfortable. And by the second appointment, they come in and they can present as different kids. So the evaluation itself involves a number of different domains. So we're looking at it, kiddos' cognitive abilities, their academic achievement, their attention and executive functioning skills, their language, and not just expressive and receptive, but we have measures to be able to look at their social communication, language, their social cognition. Can they take on other people's perspectives? Their social emotional skills, and if necessary, even motor abilities. So we have access to a wide range of measures to be able to provide a comprehensive evaluation. Now, because we realize that it's 2 appointments, which in the grand scheme of someone's life is a small period of time, we take an extensive history with parents and really want to know about that early developmental period and what things looked like. Did they meet milestones on time? Were there any red flags? Were there any early interventions? Did they have speech, OT? What was needed? What was their play like? And then another important piece is if the child is in school, is the teacher piece. So we have a number of different rating scales and a questionnaire that we distribute to teachers to get their perspective, see what things look like in the classroom. And then if need be, we also have the opportunity to observe the child in school as well.
All right, so treatment. So with a diagnosis through the assessment process, we're able to see strengths and weaknesses, as well as the level of severity for an individual if they are diagnosed with autism spectrum. And dependent on the level of severity and the age will depend on the treatment. So let's start at the beginning. So with an early diagnosis, we're thinking before the 3 years of age, this would classify under early intervention. As we saw in the Temple Grandin clip, earlier intervention is key. As early as we can get services in, these kids are sponges. We want to give them as much information and tools and learning that we can. So 3 areas that I want to talk about for early intervention. The first is speech and language therapy. And this is going to range depending on where the child is struggling. So it could be language production. So as you saw, she didn't speak, I think she said till age 3 or 4. So we want to help with that expressive language. But it also can range to pragmatic or social language. So this could be the kids that don't understand or able to utilize or express the pragmatic or social language piece. And so they can start adding that in very, very young to help their social interaction skills and their social communication skills. Next, we have occupational therapy or OT. So occupational therapy can also really help with a wide range of struggles. So we think of it, or one of the things that I think of first is sensory. So someone that is having sensory sensitivities, OT can be extremely, extremely helpful, as well as behavioral challenges. They can really help with those behaviors, as well as motor movements. So they absolutely can help. A lot of this will be in a setting where they have a lot of manipulatives or even in your own home, as well as helping with transitions. The last area to bring up for early intervention is what we call applied behavioral analysis or ABA. And this type of therapy is super specialized. Someone that is an ABA therapist has to have specialized training. And it is evidence-based for autism. So what ABA is it encourages and reinforces desired behaviors and discourages undesired behaviors. So what will happen typically is the therapist will meet with parents, caregivers, a lot of times in their own environments, their own real life home, to see what behaviors are going on that are desired, what are undesired, or what they would ideally like to see. And what they do is they utilize a lot of reinforcements in behavioral therapy in order to increase, again, the behaviors we want to see and decrease the behaviors that we don't want to see. So now let's talk about school-aged kids or kids after the age of 3. So one of the areas that Amy talked about at the beginning, I think it was in 1990 when they recognized autism to be able to give school-based interventions or accommodations through an IEP plan, which is wonderful. Some of the examples of what an individual may get for accommodations through an IEP can relate to those sensory concerns. So it could be like noise canceling headphones. It can be like a quiet place to calm down. It can be like sitting on a big bouncy ball if that helps regulate them, but able to utilize those accommodations in class. And that would be on the IEP. Also, a visual schedule. So you see, I just did a really quick Google search of a visual schedule and or graphic organizer. And this really helps kids with transitions. So, ideally what would happen, at least in my own ideal, is maybe there's like the kid has a board and there's a couple slots for the day's activities and they're able to cut out each one, maybe Velcro it on, and then they know exactly what's going on throughout the day. They can pull off as the activity is over. And if there has to be a change in the schedule, Ideally, you would have the kid help you do it, maybe switch around the schedule in order to help them learn that flexibility. Also, that can be under IEP in terms of treatment would be a behavioral plan to replace unwanted behaviors with more positive or socially appropriate ones. So this, this feels more like that ABA therapy. And with the use of an IEP, occasionally they are able to either bring in the ABA therapist to help create a behavioral plan in school, or even just use their knowledge in order to make one that fits the context of the classroom setting. And then lastly, obviously a lot of this is dependent on the school and what resources they're able to do as well, but help with social skills. And so this could be like a social skills group. It could be with a speech and language pathologist, but really working on their social interaction in the real life setting where they're going to get it all day long, which is the school setting. Next area for treatment for a school-aged kid or adolescent would be like a therapeutic school placement. One of the reasons why this could be so useful is because an individual would have all of their treatments and interventions during their daily curriculum. So every single day they're going to get speech, OT, whether it is ABA therapy or a different type of therapist, and they're able to get that in their daily routine, which could be really great if they really require it daily. And for us, parents or caregivers, that it's really hard to schedule it after school and make it all come together. It's nice to have it in one place. Another really great aspect of this treatment option is typically therapeutic schools have teachers with specializations working with these kiddos. They understand them more, they have experience, and the group work is appropriate to their developmental level. So it really fits what they need. We talked about speech and language and occupational therapy. This is definitely not just for under 3. It goes all the way throughout the developmental levels, and will make it appropriate to what they need at that time in their life. And then lastly is social skills training. So this could be in groups or individuals, but it helps one's social communication, their ability to interact in social situations. And the goal really is for them to learn social skills and how to act and respond in a socially appropriate manner, and then practice that. So whether it's in a group setting, whether it's one-on-one with a therapist, we want them to continuously practice them. So obviously what I've said, these little graphics that I have, they're not a full gamut list of treatments. It differs per individual, given their strengths, their weaknesses, the level they are on the spectrum. We can also be really creative with treatment and the different options that we can think of, depending on their areas of struggle. For our assessments, whenever we see an area of weakness, we usually give an area of like an accommodation or a recommendation of what we would say in order to help treat that area. So it's going to vary significantly per individual.
So autism has changed so much over the years, and it continues to change. So I would say that one of the most common trends that we've seen in recent years, 5 to 10, and what's been coming up again and again in research is the idea of girls and autism. And at the beginning, you'll remember that I mentioned the ratio of boys to girls being diagnosed as 3 to 1. And we're really starting to question, is that really accurate? Or are girls just kind of going under the radar? Do they present with a different presentation than what we typically see in boys? And there's a term that has been used in literature called camouflaging. And basically it describes girls who might be better at hiding or blending into their social environments. They are often quite good at imitating. So they can imitate their parents, imitate their classmates, imitate what they see on TV, and to kind of mask whatever difficulties they may have. Their communication skills tend to be stronger as well. So they tend to be more equipped at the back and forth and able to carry on a conversation And oftentimes that makes diagnosis a little more challenging. We know that girls are just generally diagnosed at later ages. I would say in our clinic, it's a common presentation for girls around 9 or 10 to come in, and that be one of the questions, where those demands and expectations for kind of deeper relationships and friendships are just not really occurring, and they're kind of withdrawing, and their parents and teachers don't really know why. Is it anxiety? Is it social communication, or is it something like autism? And often with girls and autism, their interests aren't really that unusual. I know that here at our clinic, we've seen interests in cats, in literature, and other animals, in Pokemon, different TV shows that are popular. But even though those interests are quote unquote, typical of their peers, they're often unusually intense or inflexible if you really start to take a look at it. So that's just kind of a sneak peek of one of the major trends in autism research and diagnosis. And at this point, it's really exciting and interesting, and it's great for girls to be able to be diagnosed and recognized at potentially earlier ages, but we'll have to wait and see what happens.
Okay, so we have 2 minutes. So our apologies that we thought we'd have a little bit more time for questions, but we don't have too much time. We did get a couple questions sent ahead of time. Maybe we can do 1 or 2 real fast. So one, I talked a little bit about treatment already, but recommended interventions, including ABA and other strategies for child on the mild end of the spectrum, is what someone asked. So this is a good question. This is where we can get kind of creative, what I was alluding to. So one example that I've heard lately for people that are local, and this could obviously be generalized out in the world too, but there are different places that work on social skills, maybe not necessarily for individuals with autism, again, if they're mild and super high functioning. So as an example, like Second City here in Chicago, they do an improv group for individuals. I think technically it says for like social anxiety, but it can be anyone that has some social struggles. And if you think about what communication is, it's improv. Like we're going back and forth, we're reciprocating, but we don't know what the other person's going to say or do. So that's an example of someone that's pretty mild that maybe we want to gently push is doing like an improv class. And obviously there's other types of therapy, psychological therapy, counseling can also be super useful for a lot of these kiddos in order to help understand rapport, reciprocal relationships, in order to also practice those social skills.
And I was also just thinking of those programs that are designed now called social thinking or social cognition, where it's a program for these higher functioning kids to learn some of the social skills that they need to be successful.
Yeah, definitely. Okay, our apologies. We have 1 minute, so I don't think we're going to push it with another question. So thank you everyone for coming. And there will be a recording sent of this webinar afterwards if you missed anything. So again, sorry we only had time for 1 question, but hopefully you took away something of use from the webinar.